the University of the West Indies, where she received her MBBS and Diploma in Child Health, and then went on to the University of London, where she received her MSc in Dermatology. She has worked as a pediatric resident at the Bustamante Hospital for Children and also at the Kids Clinic, and then she was a dermatology resident at the University Hospital of the West Indies, and private practice, she's a dermatologist at Apex Medical Center. Her academic affiliations, she's a member of the Caribbean Dermatology Association, Secretary of Dermatology Association of Jamaica, Fellow American Academy of Dermatology, and Associate Member, Pediatric Association of Jamaica. Well, I mention these because we know that when you're involved in these associations, you do a lot of work. Right? So she also practices at the Apex Malines and Portmore Center and is co-founder of Apex Healthcare Associates with Dr. Patricia Yap. We invite her to come to the podium and speak on effective management of atopic eczema. Dr. Ffrench.
Good morning, everyone. Well, thanks for coming, and thanks to the General Practitioners Association for inviting me. What I find with atopic eczema, it is largely a childhood disease, and as a dermatologist, I'm not really the first person that is seeing these children with it. It's usually the GPs and the pediatricians. So by the end of this, I hope you'll have a better understanding and a better working knowledge of how to approach the management of atopic dermatitis. Okay. I'll be going over these areas: what is atopic dermatitis, the pathology, the pathophysiology, the clinical features, the differential diagnosis, and of course, treatment of atopic dermatitis. Okay. Definition of atopic dermatitis, or atopic eczema. It's a chronic skin condition which is associated with hyperreactivity of the skin to allergens, which results in inflammation of the skin. It's very common, and as I said before, it's largely a disease of childhood, and approximately 10 to 30% of children will develop atopic dermatitis, whereas it's only seen in about 1 to 3% of adults. 60% of these patients will develop symptoms in the first year of life, and 90% will develop symptoms by age 5 years. However, most children outgrow atopic dermatitis by the time they're about 10 years old. In understanding how we manage, we need a very good understanding of the pathogenesis. And there are a few interrelated factors that attribute to the development of atopic dermatitis. There is the impaired barrier function of the skin, an exaggerated immune response within the skin, and as well as environmental and genetic factors. I'm going to go in a little bit of detail into the impaired barrier function, the immune response, the exaggerated immune response, as well as environmental factors. Okay. So, these would be your cornea sites. These would be your cornea sites here, and that would be the equivalent of the bricks in a brick wall. In between the cornea sites is a lipid layer, which would be equivalent to the cement of a brick wall. And in the normal stratum corneum, the cornea sites are well encapsulated by a lipid layer, and they are tightly compacted. And this is what provides a barrier to prevent penetration of the epidermis, as well as prevent water loss from the skin. Okay. Now, the main problem with atopic eczema is this impaired barrier function. And if nothing else, this is part of the backbone of the problem of atopic eczema. What you find is that there's a breakdown of the lipid layer between the cornea sites, and this causes water to leak from the cornea sites to the external skin. As water leaks from the cells shrink, so they're not so closely compacted, and they become more loosened. And this allows microbes and allergens to penetrate the skin. So, as you see here, there's a breakdown of the lipid layer. There's loss of water from the cells, and they shrink. So you see the spaces between the cells now become wider, and this allows penetration by your allergens and microbes. And this basically summarizes all of that. So here, this is a loss of the lipid layer. Okay. There is increased transepidermal water loss, which causes shrinking of your corneocytes. Right? So this allows allergens to penetrate the skin. In addition to this is why you'd find that the skin of atopic eczema patients is so dry. That accounts for that. In addition, the increased susceptibility to infections and the sensitivity to allergens is also explained by this. So why does this happen in atopic eczema? Filaggrin is a very important protein that is produced by the skin, which ensures that there's proper maturation of the keratinocytes to form an intact stratum corneum. And what happens with atopic dermatitis is that there's loss of function of the gene that orders the production of filaggrin. So the stratum corneum does not get a chance to form properly. Within the epidermis, DC stands for dendritic cells. These are our Langerhans cells, which are really our antigen-presenting cells. They also serve as immune surveillance. So basically, your Langerhans cells move through the epidermis and pick up all of these antigens and microbes that penetrate the skin. They then present the allergens to your T helper cell lymphocytes. These produce cytokines, which in turn produce IgE antibodies. And the IgE antibodies then bind to your mast cells and release a histamine. So the histamine triggers inflammation, scratching, and this is accounting for the consistent itch scratch cycle seen in patients with atopic eczema. Environmental factors. This is basically a repetition of what we've done before. Irritants, such as soaps and detergents, basically they reduce the lipid barrier further, so they aggravate the dryness of the skin. Okay. Allergens, the dust mites, pollens, can penetrate the skin as we've seen before. Microbial agents, also penetrants, but I want to emphasize Staph aureus in particular, and I will do that shortly. Food. There's a tendency to want to say if you have eczema, you're allergic to milk, or you're allergic to cheese, or you're allergic to nuts or eggs. This is certainly not the case. I don't generally routinely switch children to soy-based products once they have atopic eczema. I may consider it if it seems to be particularly severe or not generally responding well to treatment. But for the most part, most of them, it's not a direct trigger. So we don't need to be restricting their diet too heavily from the milk, the nuts, the eggs. Okay. Climate. In Jamaica, we will find that heat and sweat aggravates the itching and hence aggravates the eczema. Sometimes during the holiday times, you see a lot of children coming in from the UK or the US where it's much colder and their eczemas are horrific. I find that they probably have a more severe eczema to deal with than we do out here, because of the cold, dry climate, and they live in heated rooms, and their eczemas tend to be far more severe than ours. Okay, just a little more about Staph aureus. This is very important because most patients who have atopic eczema, their skin is colonized by Staph aureus. And Staph aureus releases proteases and lipases, which breaks down the lipid barrier. So Staph aureus in itself is a trigger for atopic dermatitis. So in breaking down the lipid layer, it then again allows penetration of allergens as well as the Staph aureus itself, or as well as other microbes which can cause infections of the skin. So managing the colonization of Staph aureus on the skin is also an important part of managing atopic eczema. How do we diagnose it? Now, there are no skin tests, there are no blood tests to diagnose atopic eczema. It is purely a clinical diagnosis. We can classify it into three main groups: the infantile atopic eczema, the childhood, and the adult. Infantile usually develops by about 2 months. It's not usually seen at birth and can be seen up to about 2 years. And in these children, the lesions are more widely distributed. They certainly start on the face, and often the cheeks are first affected, and then they can evolve and spread downwards to include the trunk and the limbs. And there's usually a symmetrical involvement of the limbs. However, the diaper area is spared. Also, in the infantile eczema, you're more going to see a more acute presentation, where you'll see more of the erythema and fine papules. Okay? So in this case, you see the cheeks, and also in his forehead. Okay. Can you press the next one? One down, one down. Okay. And here we see where it progresses to the trunk and the limbs. In colored skin, apart from erythema, it is quite common in babies to see this hypopigmentation. So if you look carefully, you can see a bit of erythema in these areas here, but there's also this hypopigmentation. And it tends to drive an anxiety about the use of steroids and the bleaching out of the skin. This little baby was actually seen by a pediatrician for, I think, 2 weeks before he presented to me. And quite correctly, hydrocortisone was used to treat. But the skin just kept getting lighter and lighter. And they were worried that it was bleaching, or the parents were worried that it was bleaching, so they ran to me. Hydrocortisone really does not bleach. And what was actually happening in this case was that the inflammation was not being adequately controlled by the hydrocortisone. And it was the inflammation that was driving the hypopigmentation. So I had to step up a little bit, step them up to a dermovate, calm the inflammation, step back down to the hydrocortisone, and the skin repigmented. So I don't want you to develop a fear of hydrocortisone in children, because it is a very useful tool. Okay, so again, we see here the infantile eczema. Again, a more acute picture where you see the erythematous papules affecting the trunk and spreading down to the limbs. And please note the sparing of the diaper area. In childhood AD, now, this tends to develop after age 2 years. The lesions are less widespread. They could become more localized. You tend not to see as much of an acute and erythematous presentation. You would more see lichenification, either on its own or along with an acute presentation of the eczema. In these cases, you see the extensor aspects of the knees, ankles, elbows, and wrists. And as the children get older, they tend to present with the flexural involvement of the elbows and knees, which is a pattern typically seen in adults. So here we see the extensor pattern. So you can see now that the skin looks less acutely inflamed. It's hyperpigmented. You see a bit of lichenification where the skin markings are more exaggerated, and it's affecting the extensor surfaces. Okay. As I said, the flexural involvement we do see, but funny enough, in our population, the extensor pattern is more common, even as adults. So this is what a Caucasian would present with, and then the extensor pattern is more common. And here as well, you can see the extreme hyperpigmentation and lichenification. And if you look closely, you can also see some of the papules associated with it. Well, this is not a typical case. This is a little girl who had quite severe atopic eczema. Let me show you a close-up picture of her legs. Now, she was like this front and back. So fortunately, this is quite an uncommon occurrence, and we generally don't see too much of this now. In addition to the clinical patterns we previously saw, there are the associations with atopic eczema. Many of these patients also develop asthma. So approximately half of the patients, which is quite a significant amount, will also have asthma, and 2/3 of the patients will develop allergic rhinitis. Dermographism. This is commonly seen where just a scratch will produce an urticarial wale. As we had discussed before, the susceptibility to infections. This is staph impetigo, but in addition to bacterial infections, you more commonly see molluscum contagiosum, plain warts, herpes simplex in persons who have atopic dermatitis, and this will occur more commonly than in those patients who do not. You also see non-specific dermatitis of the hands and feet, and the increased skin lines of the palms. That's quite common. So the hands sometimes take on a very aged look. Okay, let's go to a couple differential diagnoses. Seborrheic dermatitis often presents at birth and resolves by about 3 to 6 months, and then it re-emerges again once you reach puberty. But it typically affects the scalp in infants, commonly called cradle cap. So you see, again, the hypopigmentation and scaling. She probably has a little bit in her eyebrows as well. And this is adult seborrheic dermatitis, which is very common. Seborrheic dermatitis in adults is probably the commonest thing that I will treat as a dermatologist. Not even necessarily acne, or it is as common as treating acne in my practice. As Clive had mentioned, it commonly affects the scalp, so what people call dry scalp dandruff is probably seborrheic eczema in the scalp, and it typically affects the brows and around the nose with this excessive scaling.